technical problems logging in this time. I was extremely nervous. I actually have my bottle of Xanax right beside me here, just in case. I wanted to thank you for joining the call today, and this is our monthly call, project-wide call that we're having. So we do have all of our sites, I believe, that are on the call today. And I think Southampton will probably be joining shortly. I'm
trying to get him right now, Michael. Sorry.
Oh, that's okay. I just heard someone else log in.
Hello, this is John Schomer.
Hi, John. So what our agenda is for today is we wanted to review, provide a recruitment update on where we are with recruitment with you. We wanted to review some inclusion criteria again, just to go through that to ensure there are no questions about that. We did have great pickup right after our last project-wide call with recruitment, so thank you all for that. We want to talk a little bit about if there are certain things that you need that may help you with recruitment. I just want to put that out there, and we'll talk more about that in a little bit. As well as we want to give you some feedback on the quality assurance process with the data forms that are being submitted, and then talk a little bit about some case studies that we're going to ask all of you to participate in and to have a discussion on the line with us today. And then we will give you an update on the abstract process and also get some feedback from you there as well. So I would like to welcome our Southampton Healthcare to the project. We did train Southampton. This is their lovely pictures if you are on the internet here, that we did do a training for them on March 24th. We were out in St. Louis and had a wonderful training with them. And not to put any pressure on anyone, but I will say that by the time I was not even through security yet, they had already referred their first patient to the pharmacy, so for their MTM visit. So I'd like to welcome them to the project. And I heard another beep there. Is who else joined us? All right. I would also like to welcome Unity Healthcare to the call. I know we have Tracy Dean, who is from Unity and is the project director, joining us, and we also have Heather Free, who's the Walgreens pharmacist who's joining us on the call today. And I should have said Darren Smith is the pharmacist at Southampton. And did we have anybody else from Southampton join us? All right. I would also like to welcome back to the project Mount Sinai, Beth Israel, our New York site. Beth Israel was navigating some challenges with their IRB and is now back on board and recruiting for the project. So welcome. So this brings our total sites to 10 across the country, and these are the sites that we are currently conducting the project in. We are in the process of adding some additional possibly adding an additional site or two to the project, but this is the project team at this point in the project. So thank you all, and welcome those who are just joining us in the program. So this is a graph of the enrollment progress chart that we have been conducting weekly in the project, just allowing us to see how enrollment is moving forward at each of the sites. And the two colored graphs here show the orange is the remaining to enroll in the program, and the green are those who are enrolled currently in the program. This data is gathered through our weekly project calls with sites, and I know that Michael DeMeo, who has been conducting those calls with all of the sites, has been asking weekly for your progress tracking sheet so that we can populate this graph accurately. I will say that Albany is leading our recruitment goal and our enrollment goal with 58 individuals, and that may have gone up since the census data was submitted. So congratulations, Albany, for your success, and for the other sites for their success as well. So keep up that work as we continue through the project. What we also did is I provided a graphic here which shows you the number of individuals that have been referred to the pharmacy for MTM services, and the scheduled is the number of clients that have been scheduled to receive an MTM appointment at each of the sites. And this data was also based on calls that we've had over the last week with sites. So you can see there's a number of people that are currently scheduled in the project to have that first MTM session completed in order to be considered enrolled in the project. And we also populated this graph, and I don't want this graph to panic people at all. As you recall, we did establish our recruitment deadline as May 29th, which gives us a little over 8 weeks for recruitment. So we did take the number of individuals to reach enrollment and divide that by those 8 weeks, and we get the approximate number per week that would need to be enrolled to achieve that goal. So I know that some of our sites have come on at a later stage in the project. Some of them, Southampton, just starting the project on the 24th of March. So our goal is to get as many clients enrolled by May 29th at the latest. Any questions about that? And enrollment is considered a patient is referred to Walgreens and they have received their first MTM visit. So that is complete. So the clinic would have received back the CMR report from their pharmacy and have faxed that first initial patient information form to Health HIV. I'm going to turn it over to Carmelita, if I may, who is going to talk a little bit about the quality assurance process.
Hello, everyone. Good afternoon. I want to just talk a little bit about QA. And is that me?
No.
Oh, okay.
It's a nice touch.
There I go. I found the line, so I muted it.
Woo! I come with my own theme music. So, for the most part, all of the forms have been legible and complete, so thank you very much for that. We are still having an issue with the forms just not being able, and this may not be your fault, but just kind of not being able to be read once they're scanned through. And I will let everyone on an individual basis know if I need you to resend any of your forms. As far as the date, it's very important for monitoring that I have the initial case, on the initial patient information form, the date that that patient is enrolled into MTM, as well as on the quality, the quarterly patient information form. So if you could just remember to update the, or place the dates in the date area, that would be great. Also on page 16 of the patient information form, there are two sections. One, when's the patient's next scheduled medical appointment, and their MTM, their next scheduled or their first scheduled MTM appointment. If we could make sure that that data is also populated, that would be, again, all of this is extremely helpful in the quality assurance process, so that I don't have to keep going back to you and saying, could you please fill this out and send it back to me. So that being said, I am compiling a list of all of the patient information forms that I've received from each site. I will send you back the list. I would like for you to please look over that list, make sure that we're not missing anything, and if there's an asterisk next to it, there's also going to be a little bit of information stating what's needed, what's missing, and if you could send that back to me, that would be great, and then I will populate your progress monitoring report or your form. I'm also asking that we do one form per fax. Some of you are sending multiple patient information forms, and I generally do not, for security reasons, I don't print those off at all. So if you could just send me patient, for example, 001 as an individual fax or email, and then send me the next one so that I have them individually versus in one continuous form, that would really help me a lot. Just a reminder as well is that you don't need to send a cover sheet. Everything that you send to us is either over the secured fax or secured email, so there's no need to have a cover sheet. Some of you are used to sending that, and that's fine. But moving forward, if you just send starting from page 3 to 19, that's great. So that basically covers the QA for me. And again, hopefully by the end of the week, each site will receive their list of forms that we've compiled. Just shoot me an okay, we have it, or you're missing these, and then we can take it from there and make sure that I have everything. Thank you so much, everyone, and have a great afternoon.
Carmelita, it's Heather. I have a question for you before you leave.
Yes, ma'am.
So for some of our patients, like Tracy's been faxing the forms to you guys once I have the MTM set up, but if the patient doesn't show up for their MTM, would you like me to refax page 16 once I have a different date for the appointment if the patient shows up then?
Shouldn't be faxing that.
That's a great question.
No, I was going to say, I'm actually not faxing until they have the MTM.
Yeah, so you're not supposed to send it until they've had the visit.
Right,
Exactly.
I have not. done that, so I'm not sure if that was the question, but.
Filling out that date.
Pardon me?
Yes. So,
I have not been going back and filling in that date.
Okay.
They actually went.
So this is a great question that has been asked. So it is the first date that MTM appointment is scheduled. There is not. That's the when it was scheduled. Whether or not they attend that appointment or they have to reschedule, that is the date that should be placed on the form for us, because we do look at that data and we do compare data to see, you know, the length of time forms get returned to us, just to ensure that we have the data that's coming in to the project. So there's no need to go back and cross that off. As part of as part of the workflow, the pharmacist, after acknowledging that they have received page 2 of the form, which is the PHI information, they should confirm with the clinic when that first scheduled appointment is to take place. And both Terry and Tracy, you're exactly correct when you say that those forms are not faxed to us until the patient has completed that first MTM visit and the CMR is received at the clinic.
Oh, so actually let me step back then, because I didn't wait for the CMR. I did the MTM and then I sent.
Right. They completed the MTM.
Right.
process.
And then I sent the 3 through 19.
That is correct.
Okay. Okay. I didn't wait for the CMR, I guess is what I'm saying.
Yeah. The CMR is your trigger that you should fax that form.
Oh. CMR and the MTM, they might be interchangeable terms.
Okay.
Yeah.
So the CMR is a type of MTM service, so it's the comprehensive medication review. It's the first appointment that Heather has with the patient is called a CMR, but it's part of that. It's
Same
part
thing.
of MTM. Yeah.
Got it. All right. So I'm okay.
Yep, you're fine.
All right.
Hi, this is Sandra Middleton at Mount Sinai Beth Israel. Now I'm confused. So we don't have to wait until the CMR comes back to the clinic? It's just as long as they've kept the appointment, then we can fax the form to Health HIV?
No. When the CMR is returned to the clinic, that's when you fax the form.
Okay, I just wanted to make sure I had that right. Okay, thank you.
Because that's
Michael, I've been faxing the data extraction before the CMR, so I guess I was doing it wrong.
Okay.
So you can fax it. You can fax it to the pharmacist before the CMR. We need that to do the CMR, but you wouldn't submit it to Health HIV until after you receive the form from the pharmacist confirming the CMR was completed.
Okay, got it. Perfect. I guess now it's
yeah, I'm still in the same position. So yeah, I have to wait for it to come to me.
Okay.
Patty, so what have you been doing?
As soon as the
currently?
client has the first doctor's appointment, we do the data extraction and fax it to you, whether Jason has seen the client or not.
Ah, I see.
Yeah.
So, yeah, we should.
First appointment doesn't necessarily mean Jason saw them.
Right. So you actually should be waiting for that CMR from Jason, because that's your trigger. That's your trigger that they are enrolled in the project.
Okay, got it.
Because if Jason, if the clients don't show up, they're not considered enrolled, and we should not have a data sheet on that person available. So this is something that we can talk about on your weekly call and just kind of rectify the data sheets that we should have and should not have yet.
Michael, just a quick question if I could. So when it's done, the MTM, so I need to wait for that fax to be sent back that the pharmacist completes?
That's correct.
Okay.
Right.
So I'm in the middle of that then.
Yeah.
Had the appointment, but yeah, so I just need to wait for the paper.
Correct.
Got it. Okay.
All right, and then I have a question too. So what happens when the pharmacy does the CMR, the MTM, before we receive the intake form from the clinic? If we've completed the CMR, do they go ahead and send that paperwork into Health HIV without all 19 pages to show that the patient's been enrolled, or do they need to finish the intake form before they can send it in?
The patient information sheet?
Yeah, so the 19-page document. So on our last weekly call, or a couple weeks ago, you said that we could start doing the MTMs without that whole packet. So what happens when the pharmacy completes the MTM without the packet? Does the clinic go ahead and send in something then to show that the patient's been enrolled, or do they need to complete the intake form completely before they send it in?
They need to complete the intake form completely before it is sent in. Okay? Terrific. Any other questions? These are great questions.
One more question then. We're good to go to send them over to the pharmacy without the complete IPF?
No.
I understand my understanding was we weren't to do that quite yet.
Yes. We do not want that process to be implemented yet. It is something that the project team is discussing at this point. So we will we'll be coming back to folks in our next weekly calls after the project team has been able to review some changes that we are considering to the model.
Okay.
Hi, everybody.
And hello, how are you?
Hi, Michael, it's Patrick. Can I have everybody mute their phones for just a moment so I can make sure everybody hears this? So there's been a few sites that we've spoken with about modifying the enrollment process, and I think that's where some of this confusion is coming from. We've identified that what we have structured initially may be causing part of the barrier in you getting people enrolled and so forth. So we're discussing how to best modify it based on the comments we've gotten back. We've given a couple of sites feedback on what we think that new process is going to be, and they've given us some input. And so we're trying to approve it internally, and then once we have that, and our goal is for next week on our individual site calls to walk you through the new, what we're going to call enrollment process that we think is going to simplify this and make it much easier for you to meet the enrollment goals. So that's maybe why I think we have questions that are coming from different sites that are asking different questions, and Michael's trying to give one answer for everybody, and it's not really working very well. Okay?
Thank you. So we will be coming back with you all next week on your individual calls to discuss modifications to the model. And as you recall, part of the project was to look at the model that we had created for the project and then to modify that model as we go along through the program. So we will we'll be coming back to you with those individual questions. However, the patient information sheet should not be faxed. The initial patient information sheet should not be faxed to Health HIV until the CMR is completed. Okay?
Mm-hmm.
Awesome. So The last time that we had our project-wide call, we began to review the inclusion criteria and to really walk through that inclusion criteria. And I just wanted to take a few minutes to review the criteria with you, and to have Michael DeMeo, if you would be willing to walk through with some of the things that the sites are reporting as common barriers, and we can ascertain any additional ones, that would be great. However, with the inclusion criteria, as you recall that we are only recruiting patients who are over the age of 18 and that can self-administer their antiretroviral, so that are not being necessarily, it's not being administered for them, or they're planning to initiate ART within the next 30 days. One of the limitations that many of you have been expressing is not being able to get all of their prescriptions at Walgreens, and there has been some discussion with individual sites about that, and we are looking to recruit established patients into the program, and that means for this project having 2 or more medical visits at the clinic prior to enrollment, and that their medical records are available for up to 2 years or to the point of diagnosis, their HIV diagnosis. So these are fairly standard and very general kind of inclusion criteria. The other pieces of information that are very critical for you is to look at this bottom of page 13. Within the past year, they have exhibited 1 or more of the following, and I know that many of you have looked at missed appointments, and also with the receiving non-standard or salvage regimens patients are receiving salvage medications. However, we've asked, some of the pharmacists are now, if they're more formally, they have been in the past, but are also helping to identify patients that they may see are having medication interruptions along the way, and referring them to the clinic, or notifying the project site at the project director at the clinic indicating that this may be an ideal patient to be enrolled in the program. And I know that many of you have been talking over the past week or two that the pharmacist is usually the person that is seen most often by the patient. Instead of coming into the clinic, they're coming to the pharmacy in order to pick up their medications. We also wanted to just alert you to a change in a chronic disease medication in the project. So if an individual has a change in any of their chronic disease medications, this is also an opportunity for them to be enrolled in the project, or a recent hospitalization, regardless of whether that is related to their HIV status or not, into the program. Additionally, we are another criteria currently meeting 1 or more of the following: not achieving their immunological goal or their viral suppression. And I know that several places have been looking to see which patients are not virally suppressed and looking to enroll them in the project, but that has limited sites from being able to find patients to enroll. So we want you to think about patients that have those missed appointments or some kind of interruptions in their medication, which requires a little bit more digging into the data, into the medical record to identify those folks. And if they are initiating any new medication for a chronic condition, that would be something that they would be eligible for enrollment at risk for follow-up or having 2 or more chronic medical conditions. So HIV is considered one of those medical conditions in the process. And I was wondering, are there any questions about the inclusion criteria? Anything that sounds different to you, or are there some practices that sites have implemented since our last project-wide call that you would be willing to share with us in helping you identify patients? I know that several of the sites have been working with their case managers and doing trainings with their case managers in order to sorry about that. I understand that you're having problems hearing me. And I know that some of you are having doing trainings with your case managers or your clinical providers and kind of refreshing the recruitment criteria with them. Are there other practices that groups have implemented in order to enhance recruitment? Okay.
Hey, Michael, this is Terry.
Yes.
I mean, basically what we just started doing is just going strictly by the inclusion criteria. If they met the criteria, we're talking to them. So we're scanning that chart, you know, for hospital visits, ER visits, missed appointments, especially missed appointments, because we can see that real quickly, whether they've had missed appointments or all. And almost we hardly have any patients that hadn't had a missed appointment in the last year. I mean, that would be just unreal if somebody hadn't missed an appointment. And of course, almost all of our patients, you can make a case that they're at risk for loss to follow up.
How do you make that determination? How do you define that?
At risk for loss to follow up?
Yes.
Anytime we don't have a good phone number for them, anytime we don't have a good address for them, where we've got documentation that at some point we didn't have a good address, anybody that the case manager's list is unstably housed or homeless, anybody with, we're looking at our young people because we know just by looking at our other quality indicators that our young people are more likely to miss appointments and fall out of care. So we're targeting that 20-something age group, especially as it relates to new patients, once they've had 2 visits and get started on some medicine. So,
are there, from that list that Terry just gave, are there do other sites have other criteria that they're using to define loss to follow-up?
I can say that we have an ongoing program with Unity that they will run they use the codes for HIV like 042V08, and they're able to set it up to see when's the last time. If it's greater than 6 months since they've seen a provider, they automatically go into a loss to care list, and then there's an outreach push that we have to our care associates. So we are constantly working a list every time they come out of the 6-month window.
And thank you for sharing that. And are the care associates, have they been notified about the project or possible recruitment of the patients into the project?
Yes, they have, although Heather and I did mention the possibility of maybe at our next meeting having some time to reinforce that. Because it's, I think a lot of times it's not just one time, it's several times. So we did bring it up at our last provider meeting.
Great. Are there other?
I think one of the tacks that we kind of took here in Albany is that unless it's absolutely obvious that they don't qualify, they don't have any other diagnosis of HIV. They've never missed an appointment. Their viral load is completely perfect for the last 15 years. We talk to them and kind of go through those criteria and just see. We just quit. We just really quit trying to call out folks. We just started kind of talking to everybody. I mean, unless it was just completely, absolutely obvious that they did not meet the criteria, because really, in our practice, we almost don't have any patients that don't fit in that criteria somewhere.
I have a question. Michael, you know all the sites, and I don't know how we match up. I feel we are unique in that we are very spread out. We have many different clinics, so at any given time I may just have myself, so I'm not sitting next to other people. It sounds like people are recruiting sort of shoulder to shoulder, and I didn't know if anybody else is dealing with multiple clinics and how to organize it that way.
That's a great question, and I believe that Unity is unique in that case. I know that Mount Sinai Beth Israel, Sandra, are you in the clinic?
No, actually I'm not. I was actually just going to say, me too. I don't have multiple sites, but I'm not actually located where the clinic is. I'm actually I'm not too far away. I'm up the block. So basically what I've done a lot of, or tried to do a lot of education of the providers in the clinic. I've sent out emails. I have posters. I've given them handouts. I try to nudge as much as I possibly can, and I'm a pretty good nudger. Okay. I've made posters for the clinic. I've had individual meetings with some of the other programs that we have there. We have a care coordination program, so I've kind of honed in on all of their staff meetings and just, requested 5 minutes to sort of push the MTM program.
Got it. That's a great idea.
It's constant, just bringing it up to people, and trying to be in the clinic as much as possible so people see my face, so I can sort of hound them, but in a gentle way. At least I hope it's gentle. And, just reminding them, oh, you're seeing this patient, maybe this patient might be eligible. I also review for the next day all the patients who are scheduled. I've come up with a sort of cheat sheet for the providers to talk to the patients about the protocol, along with the patient agreement and the HIPAA form, and I shove it in their charts as well. Because luckily we still have paper charts. We're not all electronic.
Oh, that's nice.
So yeah, so all of those things, so they have a visual reminder, and then I kind of hover around at the end of the day and go, what about my papers? Did you fill out my papers? What's going on with my papers? So yeah. Yeah,
because some of our clinics are literally across town, like all the way in another quadrant. And you know, it's a half-hour metro from one to the other. So yeah, you know, I thought about like continuing with the emailing and stuff, but it's harder because as a team, when you come in, you're constantly talking about it. But I may not see somebody for a month, month and a half.
Right. Exactly. Like I said, I mean, I created this little sort of cheat sheet, and also allows me to collect data on if somebody says no, why they say no.
Oh, that's great.
So, you know, because I can't, unfortunately, I have other things, so I can't be in the clinic all the time.
Right.
But at least this way I know, you know, what's going on. And also I gave everybody my contact information. They have my numbers that they can call me if they have a patient that, you know, maybe the doctor doesn't have the time because there's too many people, but he wants the patient, you know, to at least talk to somebody about it. And I'm lucky enough that I'm close enough that I can run over. Like, that's what I was doing all morning. I was actually working with a patient all morning to try and get him into the program. But,
oh, that's great.
And it did. It worked. Yay. Yeah, but yeah, that's what happens if you're not based in the clinic. It's kind of just trying to sort of put it up in people's faces as much as you possibly can, and if they let you put things, that's always really helpful.
Right.
Right.
Hi, this is Diane from.
I was going to say, Diane, go ahead.
Well, we just have 2 different locations, and so what I ended up doing, knowing that I was not going to be available during that time, I actually got some help from a case manager at our second location and someone on the nursing staff at this location to try to make sure that we had as much coverage as possible. And so then I did, you know, a training with them, and I gave them the binder, and I gave them all the information that they would need, so that they would be somebody who could be consulted and who could consent patients and help with that process. And that has been really great because, you know, as much as I try to be here, you know, when the clinic's open, you know, with several locations, it's just impossible.
Right.
And so I was lucky enough to get that help from them. And I would say at this point, people in the clinic go to them more than they even come to me. And so that's been really useful if you can get, you know, a point person at another location. I think that could be really helpful.
I have had a few referrals from another nurse and another provider. So yeah, it's the momentum and then fighting the deadline. You know what I mean? It's that it feels like it's so close, and it is close.
Yeah, I would say as many hands on deck as you can get. You know, take them.
Okay.
Great. And Sandra, I was going to ask you if you would be willing to share your cheat sheet with us.
Oh, absolutely.
Yay!
I was going to offer that, but then somebody else started talking. I didn't want to, like, jump in. But, yeah, I'm more than happy to share my little cheat sheet. Just let me know where to send it, and it can be disseminated. It's not a problem.
That would be really great. I was afraid to ask, but I would love that.
Oh, definitely. Listen, hey, we got to work together. Okay,
That's right.
So just let me know. Send it, and I'll email it out, you know, whatever you want.
Michael, are you able to help us connect?
Yeah, I will do that. I will just send that out to me, Sandra, and I will distribute it to the group.
No problem.
Thank you.
Michael DeMeo, are you, can you talk about some of the reported challenges?
Sure. So I put these together just based on some of our calls over the past few weeks, since now I'm talking to all the sites, about, you know, what are some of the ongoing challenges with recruitment. And really they're kind of clinic specific. There have been some staffing issues at different clinics. There have been sort of, you know, some processes that had to be worked out. But these are some of the things that have been sort of a theme across all clinics. And the one is that patients don't want to switch to Walgreens. It's not been as big as a problem as it was in the very beginning with our first sites. We've been able to work through some of the issues around that. But some patients, and we just had this call with, this issue came up with Beth Israel last week about patients do have an established relationship with other pharmacies, there is not an incentive for them to switch. So that's one thing. The other is a bigger one, which is sort of systemic barriers that are really not in your control, and that is issues around ADAP and whether ADAP in your state is contracted with Walgreens and if patients can get their medications there. There are also, I think it was with Care Resource, or maybe it was, I'm doing 10 sites now, it's hard to keep track. But anyway, there are some private insurance plans that have restrictions on the pharmacies that can be used. So patients who are privately insured or have been put onto private insurance through the state exchanges are not able to use Walgreens. And then the last one is project protocol. There are some things that you can't do that are not that are outside of the guidelines of the protocol. There's only 1 or 2 sites where that's come up. I've also heard that participation requires some additional time and travel and visits, and that has been a barrier. So these are just, a few that I think everyone can sort of relate to, but there may be other ones that all the sites would benefit from hearing about, even if it doesn't feel like they're applicable to all the sites. So does anybody have any other issues around recruitment that they've been encountering that aren't listed here that we could discuss now?
Just remember, you may have your phones on mute. Okay.
Great.
All right. You guys are quiet today.
I know.
So I did want to ask around helping you facilitate recruitment. If you could just think about discuss what your needs are. Do you need certain tools, flyers, something else that you feel like you could really use that could help you with the recruitment process, or how we as the project team can help support you in that work? So does anybody have any particular things that they think they would really, that they need in order to facilitate recruitment?
Could you have somebody here next Monday morning to work the next 3 weeks on nothing but recruiting patients?
I wish.
We could get it done, I believe.
Yeah.
Nothing. I don't want them to have to do anything else, just recruit patients.
Exactly. That is something that we cannot do. I'm sorry.
So what good are you then?
Yeah, I know. It's true.
So everyone, this is Ambrose, especially the pharmacists on the line, knowing the push that the clinics are going to have over the next 8 weeks, make sure that you're prepared as well on our side to get these patients scheduled as quickly as possible and get these CMRs delivered as soon as we can, so we can help everybody meet the goals of the project, and keep in mind the staffing concerns that might come along with that, and reach out to me if you have any questions or need support, especially over these next 8 weeks as we near the deadline.
And I will say too, just from just as we're talking about recruiting, I mean, I don't know what other places they're doing, but Ashley's been here in Albany. Ashley's been helpful. The pharmacy's been real helpful, helping us recruit folks that may have slipped through the cracks over here, or maybe are coming in to pick up their medicines, maybe just haven't had an appointment here or not scheduled to come back for a couple of months. But the pharmacy's identified that there may be issues around that might qualify them, and kind of sending those people our way too, and that's been very helpful.
Do you, Michael, do you have flyers that are more specific just for the patient, something I can give them to look at, and then we can, because you know the patient information, that's much more weighty to read through. So is there like something to catch the eye first?
We can send you examples of what the other sites have put together.
Okay.
So that you can have those.
Okay, that'd be great.
Okay. Well, if you think of things that may be helpful for you in recruiting your clients and getting them enrolled in the project, please reach out to us and let us know so that we can help support you in that process.
Mm-hmm.
So we have 5 minutes left in the call today, but I did want to just indicate that we have 2 abstracts that have been submitted regarding the project, and you see them listed here on your screens: the International Conference on HIV Treatment and Prevention Adherence, as well as the 2015 National HIV Prevention Conference, which is going to be in Atlanta the 6th through the 9th of December. So I just wanted to kind of alert you to that, to keep your eyes out for those if you are attending any of those conferences or any of your staff are attending at your clinics or pharmacies attending the conferences, to let us know so we can participate. You can attend our sessions. The other thing was, are there other conferences or that you believe would be a good conference for us to present this model at, whether that is a national conference, state or local, that you may participate in or have participated in?
Is the Ryan White going to be in D.C. this year?
The Ryan White Conference will not be held this year. It is going to be the U.S. Conference on AIDS is going to be here in September. However, abstracts are closed for that at this point.
I don't think Ryan White's doing an all-parts meeting anymore, are they?
No, they are not.
Oh.
Yeah,
we didn't get to our question today, and I apologize for that. I need to make our agendas a little more streamlined, but good discussion anyway. I wanted to just alert you the next project call is going to be May 13th, at the Wednesday, May 13th at 1 p.m. And I just wanted to check in with folks. I know that we have added some new sites to the project, and I just wanted to see, is the day and time or the date of the project-wide calls still workable with people, or should we send out a doodle request to see which day and time works best for the folks to participate? Okay.
Michael?
Well, if you, yes.
Hi, this is Christy from Care Resource. How are you?
Good.
Good. I was wondering if maybe you can push the meetings until 2 instead of 1, because a lot of us go to lunch at that time.
Okay.
If that's okay with everyone else.
I may be in clinic. That's probably my only caveat.
Well, what we'll do is we'll send out a doodle request and ask people to tell us times that work best for them. I know that originally this time was selected because it kind of worked for the most people, but we can revisit that. Okay? Well, thank you all for participating. I do want to say, please make sure you get your data sheets into Michael prior to your calls so that we can update our graphic and show you how we're doing as a project team. And as we move forward, we just want to really reiterate how important recruitment is in reaching that May 29th deadline. So if there's things that you need from us, let us know, and we look forward to talking with you on your weekly calls.
Okay, Michael.
Thanks so much. Yes.
Hey, this is Carrie in Albany. Just real quick, I just think that you guys need to send Ashley and I to Atlanta for that meeting. It's just up the road now. Just up the road.
Just up the road. Exactly. Point. Good point. Good point. Thank you all so much.
Thank you.
Thank you.
Thank you.
Hey, Michael.
Yes.